All right. So now I'm talking about electrolytes. I've got the simple nursing section, the study guide that has the page where it has all the electrolyte imbalances. I'm going to go over them quickly, but hopefully thoroughly enough to where you guys have what you need. So electrolytes, what they do is they charge our cells to do their job, to communicate and function. They all have various functions, and I'm going to talk about the function that each electrolyte plays, or at least the big one, the ones you've got to know, and what happens when it gets out of balance. You know, the name of the game with all of this is keeping stuff in that therapeutic range that we call homeostasis. All right, so potassium is the first one we're going to talk about. Potassium is an intracellular electrolyte. You've got electrolytes on the inside of your cell, electrolytes on the outside of your cell. Now, when we test electrolytes, when we test, we draw blood and we send it to the lab and the lab runs them. Well, that's testing the amount of the electrolyte that's in the vascular space, it's in the blood. It's not, because we can't really test how much is in the cell, but we go by what the amount of it that's in the blood, and see if it's where it should be, if that makes sense. So potassium is primarily in the inside of our cells, and then sodium is the big one that's on the outside. Now sodium and potassium, they have an inverse relationship. So this is what's going on between those two, and this is what I mean. Okay, so let's play the game. This is a cell. Potassium, K, that's the abbreviation, or it lives inside the cell. Sodium lives on the outside of the cell. There's this mechanism, this thing called the sodium potassium pump. And this thing's job is he's got one job, and it is to keep sodium on the outside and potassium on the inside. It regulates that, and it keeps things in balance. And so that's kind of the thing. So if something goes wrong with that sodium potassium pump, then we got problems. But that's just sort of some pathophysiology that you'll need to know a little bit about, and it's helpful to know. And the deeper you get into nursing school, it'll come up again. But just know that inverse relationship there in the sodium potassium pump. So most of the time, if our potassium is elevated, our sodium is going to be down. And if our sodium's up, potassium is going to be down. Whatever, they're going to be opposite of one another. So these ranges, he's got them listed right here. Potassium's 3.5 to 5. That's most textbooks, most things you look at is going to say that. Some may differ a little bit, but if you can remember these, you're in good shape. Now, most facilities each facility has their own set of lab values, and they might be a little different from one place to the next. But if you can remember these, you're going to be fine. So the function of potassium is, when you think potassium, think heart. It causes our smooth muscle to contract. Our heart's a big muscle. So potassium being in that range plays a major function on how our heart pumps and how it functions. Now, there's a lot of things listed here on this study guide, and they're all good, but I want you to know that when we have a high, especially a high or low, but mainly a high potassium, we are really worried about cardiac arrest. A patient, when it has the elevated, it says peak T wave, that's that little EKG thing. And I'm not going to tell you a lot about that. I'm not going to get too much into the EKG stuff, the heart rhythms. That's a next semester type thing that we'll talk about. But just know that we are concerned that we're going to have a heart attack or something like that's going to happen. So that's the big concern. Now, there are other roles that potassium does play, because it affects our smooth muscle. Our deep tendon reflexes are affected by it. But just really lock in your head, potassium, heart. Now let's talk about how we get a potassium imbalance. We get a potassium imbalance about the same way we get any other electrolyte imbalance. So you lose electrolytes anytime you lose fluid. So you'll say you're losing fluid because you're peeing too much, or you're pooping too much, or you're throwing up, or you're sweating a whole bunch. Most of the time, potassium is lost or retained through the kidneys. Kidneys is a big regulator of our potassium. So someone that has renal failure, has kidney failure, they are most likely going to have high potassium, or at some point they're going to be at high risk for it. So we'll do stuff to either make them diuresed, give them some Lasix, or if they're bad enough, we'll put them on dialysis. We got to get them peeing, somehow, some way. We got to get rid of that potassium. That's how we'd fix a high potassium. The way we fix a low potassium is we're going to give them supplements. You can give them PO potassium. You can encourage them to eat foods high in potassium. We're going to talk about that toward the end of this talk. But we never, ever, ever push IV potassium. That will kill someone. It will surefire kill them. That's, from what I understand, that's how they execute people that are on death row. Is they go out there and they start IV and they push IV potassium and kill them. But you can give IV. You do give potassium IV, but you have to give it extremely slowly. And it's usually given in this little bitty bag that people call K-riders. I've been a nurse for a long time. I never heard that term until I got here in Arkansas, and I hear it more. But anyway, it's just a little bag of potassium, and then you give also a big bag of like normal saline or something with it, and that helps dilute it. And you want it to go really slow because potassium is really rough on our veins and it irritates our veins. So that's one reason why we do it. And then, of course, obviously, if you give it fast, you could really jack someone's heart up. You don't kill them. So that's potassium. Okay, now on to sodium. Sodium is salt. Sodium plays a big role in our blood pressure, maintains our blood volume, because wherever salt goes, water is going to go. And water and salt kind of follow each other because there has to be that appropriate amount of salt and water mixture is isotonic. And that's what replaces blood volume. So our blood pressure is largely dependent upon sodium in our blood volume, the volume in our body. Okay, the big thing that you need to think about symptom-wise with a sodium imbalance is neuro. All right, because too little or too much salt causes that fluid shift that I talked about in the fluid video. If we're hyponatremic, it's going to cause, so there's too little salt on the in the outside of the cell. It's going to pull fluid out of our cells, it's going to pull fluid into our cells to kind of help regulate that, and it's going to cause a shift. Either way, hyper or hypo, it's going to, and whenever you have that, you have problems with your brain. You have neuro problems. So let's look at some of these symptoms. Well, it's more so with hyponatremia. So think more so hyponatremia with the neuro, but you have a headache. You will have cerebral edema, so swelling around our brain, seizures and comas. Any of those are dead giveaways, hyponatremia, okay? Patients getting irritable, patients getting confused, hyponatremia, because we've got a fluid shift going on. It's probably what I'm thinking. They can do other things. It does play a role in our muscles. But if you could just think neuro with hyponatremia, you're in good shape. Now let's look back at hypernatremia. We got too much. Well, usually if we got too high of a sodium, we're going to have some swelling because we probably got some fluid that's went with it. Nausea, vomiting. But that's not always the case. Sometimes we could have just lost a lot of fluid, just straight up fluid, and so now we're really concentrated on the inside. And sometimes you can be dehydrated and have a high sodium, but you just don't have the fluid to match it. So the question or whatever is going to give you probably a lab value or something, but you could be dehydrated. And in that case, if someone has got let's say someone's got, it's the prime opportunity to use some hypotonic solution, like some half normal saline. So let's say somebody is dehydrated, so they do need some fluid, but their sodium is like 150. So we know a normal sodium range, according to this, is 135 to 145. So the sodium is high. We would give them a really diluted hypotonic solution to help balance that out and give them some fluid. But with hypernatremia, they're going to be flushed. They're going to have red face, things like that. Anything that's caused us to just lose water could do it. Now it talks about low ADH. You'll talk more about ADH probably your senior year, but it's anti-diuretic hormone. And simply what that is, it's very self-explanatory. It's a hormone made in your pituitary gland that causes you it regulates the amount that you pee. It's anti-diuretic, so it keeps you from diuresing. And it plays a role in that. Okay, moving on to chloride. I'm not going to talk a lot about chloride. Just know that wherever sodium goes, chloride goes. Sodium and chloride are always together. If you can understand sodium, you understand chloride. There's really not much difference in those two. Do know these values though. Okay. All right, magnesium. Okay, so magnesium, it's another one that plays a big role with your heart. So a good way to know this one is if magnesium is hyper. So if you have too much magnesium, things are going to be slow. So your heart rate will drop. You will have hypoactive bowel sounds. Your breathing will slow down. Everything you basically just call you low and slow with magnesium when it's elevated. Now this could be caused. Pretty much they're all caused the same way. You have something going on with your kidneys, and it's called use to retain it. So it says renal failure, alcoholism, and malnourishment. That's a big one. Okay, so alcoholics, I think it's twofold. I think maybe it's something with the chronic alcohol use that affects the way the GI tract absorbs these electrolytes, but it's also alcoholics are very malnourished in general because most of the time they don't eat a good diet. If they eat at all, because they're just drinking all the time, like a true alcoholic, not just somebody that likes to have a good time, but like a alcohol dependent type person. Magnesium imbalances are pretty common, but we're just going to replace it. That's what we're going to do to treat it. So if the magnesium is too low, it's going to be the opposite. So your muscles are going to be real rigid. Your heart rate's going to be elevated. You're going to be tachycardic. Your GI tract, you might have a excited GI tract, so you might be having diarrhea or something like that. I can remember being a cardiac nurse back in the day and having a patient that was like really tachycardic, like, heart rate just like, 140s or something. It wouldn't calm down. I was getting worried. I told my charge nurse about it. I was a new nurse. I didn't know much then. And she was like, "Oh, well, he's got some PRN magnesium. Just give him that." So just give him some IV magnesium. I did. Fixed him. His mag was low, and he just needed that to help kind of calm him down. So magnesium and potassium play big roles with their heart. So that's Like I said, I mean, it causes, pretty much the causes are kind of all similar. Anything that's going to cause you to pee too much, poop too much, or throw up too much, or sweat too much is going to cause, or too little of those things. All right. Calcium, remember the 3 B's. It functions to keep your bones strong, form blood clots, and it also affects your heartbeat. Now, if you have too much calcium, you could have kidney stones, you could be constipated, bone pain, severe muscle weakness and lethargy, hyperparathyroidism, cancer, and immobility. Okay, so your parathyroid hormone, it's a hormone that I believe it pulls calcium. Yeah, it pulls. If I'm pretty sure this is correct. Parathyroid hormone is a hormone that pulls calcium out of the bones and into the blood. It plays a role in regulating calcium. So if you have too much of that, something's going on with your parathyroid, then it could cause your calcium to go up. Now, hypocalcemia, everything is going to be rigid. You're going to be real tense. There's a thing called the Chebec sign and the Trousseau sign, and that's like hallmark. Like, okay, we have a hypocalcemia problem, or calcium is too low. Trousseau sign is where you put a blood pressure cuff on them, you tighten it up, and it makes their arm do that. Okay, and the Chebec sign is where you tap them right there, and they do that twitch thing. My kids have been loud. But anyway, yeah. So, and then also think parathyroid. So, just the opposite, right, of what I said. If you have too much calcium, and that is a lot of times called by hyperparathyroidism, too much parathyroid hormone. If you've got hypo, so you don't have enough. If you don't have enough of the parathyroid hormone, you could have hypocalcium because it's just staying in your vein. There's a drug called calcitonin. Calcitonin is a drug that we take, and it pulls calcitonin is a hormone, is what it is, and it pulls calcium from the blood into the bone. And so calcitonin takes calcium from the blood, puts it in the bone. Parathyroid hormone pulls calcium from the bone to the blood. But the big things to know for tests. Okay, bones, anything causing something with some bones, think is something going on with our calcium, or what is our calcium level? Just at least ask that question as you're thinking this stuff through. Anything with the parathyroid hormone, look at that. Remember, too much parathyroid is probably going to mean you're going to have hypercalcemia. Also, 100%, that Chebec sign where you tap them, they do that. They probably got some hypocalcemia. They do. That is like the thing. And then also that Trousseau, they pump the blood pressure up. I think your arm turns in. Okay. And then phosphate. Now, phosphate, in that simple nursing video, it's like 8 minutes long that I posted. It talks about the relationships. So magnesium and calcium are friends, right? They're usually, if one's high, the other one's high. One's low, the other one's low. They usually kind of follow each other. Potassium and sodium, they're opposite of one another. So one's high, the other one's low. Calcium and phosphate, they have an inverse relationship. They are enemies. They don't like each other. All the time, if one's high, the other one's low, the other one's high, the other one's low, right? Phosphate, that's really the big thing. Yeah, so think about this with phosphate. All the stuff I just talked about with calcium, right? If they're showing signs of hypercalcemia, then that's going to be the signs of a low phosphate. If they're showing signs of hypocalcemia, it's going to be the same as a hyperphosphate. Does that make sense? So they've got that inverse relationship. So you'll have to think on that for a little while. But yeah, they're the same, but they're opposite, if that makes sense. Hypercalcemia, all the things that go with that go exactly with hypophosphatemia and vice versa. That is electrolytes in a 20-minute nutshell. So now let's really quickly. I don't know how where you're gonna be able to see this, and I'm not gonna. There's a lot to teach on this, but this I stole from Simple Nursing video. But this is important. Okay, and I don't have the best handwriting. I don't know if you want to pause this and like write this down. Your textbook probably has a list of foods too, but I want to at least cover it. Because big with these tests is also knowing what foods have what electrolytes. And you'll need to teach the patient accordingly, right? So if the patient needs to be encouraged to eat things that's going to make potassium high, well, you know potassium-rich foods. If the patient has issues with high sodium, well, you need to know what foods have sodium in them to tell them not to eat them. And that goes with all of them, right? They have calcium issues, you want to know. Okay, green leafy vegetables, they have been around forever. I remember being in nursing school, and the joke was that if you didn't know the answer, and green leafy vegetables was a choice, pick it. Green leafy vegetables are good for potassium. They also, they have magnesium for spinach. Yep, so spinach has a lot of magnesium. Green leafy vegetables, calcium has green leafy veggies. Most people think milk with calcium, and it does, but actually green leafy vegetables is number one. Phosphate has dairy, meats, beans. And then chloride is going to be anything that has salt. So the big dog with salt is anything that's canned or processed. Canned foods always have a lot of salt in them. Fast food, all the stuff we enjoy to eat, or I enjoy to eat that I don't need to be eating. Canned food, processed food, fast foods, all high in salt. Magnesium, spinach, almond, yogurt. Okay, we always think bananas with potassium, and it's one of them. But actually, green leafy vegetables is even higher up there. But I don't know what our test is going to look like. But I know a lot of times this is tested. This is like a select all and apply. You've got a scenario, you got a patient, they just can't keep their potassium up. Which of the following foods that we encourage them to eat? We're going to have a list of like 8 foods, and you got to pick all that apply. And let's say green, and we may have all of these. So salt substitutes. Think about it, okay? It's a salt substitute. It ain't real salt. So salt and potassium have opposite relationship. So because it's like fake salt, it's going to have potassium in it. Thought that was interesting. But anyway, there's our foods. Your textbook may have a list of them. I didn't see any in the Simple Nursing Study Guides. This actually came from Simple Nursing video. And also, I do have a Simple Nursing account, and if any of you don't have an account, don't have access to one, and you'd like to watch some of those videos, if you'll get with me, I make it, let you use my account or something. All right, that's Electrolytes.